like we've talked about, with this, you get to the end of it, you run somebody through the profile, and you're not done. We still don't know what the problem is. The whole point of the profile is to put you into a better position to have more information to then make a better decision about what you do next in your assessment. You can ask yourself these questions. It doesn't matter. I know myself, when I run somebody through, all of these are kind of jumbled together, because sometimes there is an individual that you're looking at where it's very obvious that their left knee was the biggest thing the whole time. Every time you looked at a shape, there's something going on with their knee. Sometimes when you take somebody through the profile, you have to give the same reminder, hey, keep your chin level. Hey, keep your chin level. Hey, keep your chin level. And that stands out. Sometimes you run into an issue where they have pain, and like I said, when we run into that issue where they have pain, we can't just automatically jump to, ooh, they have pain, I found it, good to go. That's not what we're looking for here. If somebody has pain one time, it is what it is. Remember, pain is a subjective experience. Doesn't really tell us anything. But if I'm consistently seeing, or they're consistently telling me they're having some level of pain, sometimes that stands out. So I'd love to be able to say, just ask this one question at the end of every profile and you'll be fine. But it's really more, you have to be aware of all of these, because not every time, but usually one of these is going to jump out at you with the patient that's in front of you. I just don't know which one it's going to be. And you're not going to know which one it's going to be. So that's why I said, kind of, when I'm running somebody through the shapes, I'm here taking them through the criteria, I'm looking for the criteria, I'm leading them through this experience, trying to observe things, but at the same time, I'm also trying to be detached and look at it from an outsider's perspective, from a large overview standpoint. What are the big things that are jumping out to me? Because those big things that jump out to you are the things that I need to investigate and get more information on. Because we know they have knee pain. We know their shoulders bothering them. We know their back's bothering them. Any entry-level clinician can have somebody that comes in with knee pain, look at knee pain, confirm it's knee pain, do some knee special tests, and start treating the knee pain and not make that patient any better. That's not why you guys are here. So what we need to do is, we know that's there, it's not giving us any information. Now, we don't want to swing so far to the side that that patient comes in with knee pain, we run them through the profile, and the profile and everything we look at tells us that it's their neck. I'm just making stuff up, I don't know. Tells us that it's their neck. We check their cervical range of motion, we do palpation, we do some special tests for the neck, and after we're done, 45 minutes later, everything we did was for the neck. We're like, see ya, high five them, fist bump them, kick them out the door, we'll see you next time. What do you think that patient experience is going to be like? They came in with knee pain. You didn't look at their knee. You didn't touch their knee. They came in with knee pain, and that crazy person went and started looking at my neck. Now, clinically, if that's what everything told us, clinically you were spot on, but we're dealing with other people. What do you think that experience was? Do you think they're going to walk out of there being like, oh man, that was awesome? Or do you think they're going to walk out of there, okay, I came in with knee pain. They looked at my neck. I'm going to find somebody else. We have to remember, we're dealing with people. If you guys came to this class, if I come in here and I start talking about Taylor Swift, this is now Swift economics. And we're going to talk about the economics of Taylor Swift and how that's helped football and how that's helped the Kansas City Chiefs. That's what we're going to talk about all semester. What would you guys do for the evaluations at the end of the semester? It was entertaining. I learned a lot about Taylor Swift, but that is not what I signed up for. It was horrible. You guys would give me all ones, maybe a couple fives because I was entertaining, but that's not what you came in expecting. So we have to keep in mind with that eval. Everything's pointing towards the neck. Everything, they come in with the knee, but everything we're doing is pointing towards the neck. We need to spend the majority of our time figuring out what the problem is, which means we're going to spend a lot of our time away from the knee. The last thing that you do with somebody the last one or two things you do with somebody in any interaction, that's what stands out to them the most. So if I tell an amazing joke at the beginning of the class, I open up with this great joke. You guys all laugh. I have to be like, stop laughing. Let's get serious. My bad. I start out with a joke like that. And then the rest of the class, I talk monotone like this. This is the note. This is the slide. What did you see? A consistent joint. A consistent motion that was missing. Pause. Problematic. The same criteria, quotations, feet together, was a problem many times. Pain? No. Unless the pain was consistent in nature and location. Next slide. I start with this amazing joke. I teach the rest of the class like that. You guys are going to walk out of here, man. That guy, he's boring. I started with a great joke. You're going to remember the last thing you experienced. So if we have that situation where that person comes in with knee pain, we do our evaluation. We look at the neck. What do you think the last thing we need to do for maybe the last 5 to 10 minutes of that session is? Put our hands on their knee. Talk to them about their knee. Make them feel like we're investing time and energy for their knee. Now, I'm not saying that's a token thing that we're doing, because remember, we knew coming in that the knee was an issue. We needed to figure out what else was going on. We've invested time and energy in this. We now need to go back and make them feel like we're doing and providing the service they came in for, a knee evaluation. Now's when we go back, we let them feel like we're doing stuff with their knee. By this point, we have more information about everything that's going on, so we're in a better position to decide what we need to do at that knee. So we're going to do things at the knee. We might look at range of motion, we might do some palpation, we might do some other things. We might put them in weird positions and look at their knee because everything else told us that it's not a knee. What we know about the fascial lines, we might take some of the slack out of the fascial lines, reposition them, and then we'll do a knee assessment there. But we do something with their knee so that they walk out thinking, he just took care of my knee. Did some weird things with my neck, but he took care of my knee. So we have to balance that out. And we get there by looking for what that consistency is. Now, when we finish, what are our options? The nice thing is, you guys have learned all of these options in undergrad. We're going to look at range of motions. We're going to look at mobility tests. We're going to look at more shapes. We talk about the critical shapes in here, 6 critical shapes. There's 21 and a half shapes. Why 21.5 and not 22? Because the last shape, the pistol, is one that I don't like and I think is impossible, but we still have to leave it on there, and so I devalue it by only giving it half a point. So 21 and a half shapes. And there have been many times where we'll run somebody through the critical shapes. We'll have an idea that is a hip extension problem, but in the critical shapes, we look at hip extension in the setup for back rack. We look at hip extension in the setup for short overhead. And then the only other time we look at hip extension is this hip in the bottom of the lunge, the setup and the shape. So we only look at hip extension with our feet here and with our feet really asymmetrical. Gives us an idea, but if I'm really concerned about something going on with hip extension, I might want to look at a few more shapes before I have a really good picture of, is this a symmetrical issue? Is this an asymmetrical issue? Is it just a little asymmetrical issue? Is it a big asymmetrical issue? So to do that, I might want to look at some of the other shapes that we haven't covered in class that fall into our extended series that look at extension of the hip, extension of the lower body in multiple different ways. So I might run them through the 6 critical shapes, and then I might look at 2 or 3 other shapes. We're doing some stuff with the helicopter services with Mercy. And we're putting those coworkers through kind of a fit test. They want to see if their coworkers, their employees, meet the physical requirements of the demands of their job. And so one of the things that we put together as part of this fit test is a movement assessment. Part of that was a shapes profile. We run them through the 6 critical shapes. Then I spent time with these individuals, see what they do, see what their day-to-day activities consisted of, and realize that, when we look at the critical shapes, it's a good starting point, but we're kind of missing some of the other things that they spend a majority of their time doing. So for them, we look at the 6 critical shapes, and then we have 3 additional shapes that we need to look at that's very specific to that population. If I were going to take a baseball play, if I were going to do this with a baseball team, we would look at the 6 critical shapes, and then we would look through several more upper body shapes because of the nature of baseball and how upper body dominant it is. For a soccer athlete, I might not look at all those upper body shapes because if you're using the arms in soccer, you're not playing soccer right, unless you're the goalie. So we might look at more shapes. We might go through and look at some mobility tests. Yeah, they all have those fancy names, the Thomas test, the Ober's test, that's the sideline one that looks kind of at the lateral hip. Think glute med, IT band, something like that. You might do some variation of a toe touch. We might look at range of motion, like we talked about on day one of class. It's not just we sit somebody on the table, we flex their knee, and it's a knee flexion problem. We need to look at knee flexion. We need to look at the range of motion of that joint a couple different ways. We have active, we have passive, and then we have different positions we can put that person into. Looking at how much the shoulder internally and externally rotates is very different if we look at it up here versus if we look at it down here, versus if we look at it with the arms straight, versus if we look at it straight out to the front. Each one of those positions tells us something a little bit different about how the shoulder rotates. And if all we do is look at shoulder rotation here, and we make this giant assumption about all of shoulder rotation, you know what happens when you make an assumption? We might be right about what's going on here, but we might not be right about what's actually going on with the shoulder. So we have to use the information we have up to this point in time to help us filter through the range of motions that we're looking at. And again, one of the things we try to do with this is we try to use the information that we get from the critical shapes to be more efficient with the skills that we already have. Somebody comes in with knee pain, what ranges of motion are you going to test? Let me ask you this, better question. Somebody comes in, they just complain of knee pain. Can you even predict what ranges of motion you need to test? Do you have enough information to gauge, I need to look at these ranges of motion? Do you have enough information to look at that? You can probably safely say, well, I'm going to look at flexion and extension. Then it gets kind of gray after that, right? How many knee pain patients have you run into where tibial rotation is something you've felt like you needed to look at? Well, if we go through and we get an idea of how this person moves, we've profiled their movement, we've profiled their behavior, we can start to have an idea of, I need to look at shoulder external rotation. When their elbows above their shoulder, things look weird, I need to look at rotation in this 90-90 position. Or everything we ran into is when their arms were straight, I need to look at range of motion with their hands down by their side. We can start to put together a framework of the range of motion that we need to look at. Instead of just taking that shotgun approach of, I'm looking at all the ranges of motion of all the joints in that area. I'm going to look at flexion and extension of the knee. I'm going to look at tibial internal external rotation. We do all that with the knee extended and the knee straight. Then you got to look at the joint above and below. I've got to look at plantar flexion, inversion, eversion, dorsiflexion, hip extension, hip abduction, hip internal rotation, hip external rotation with the knee flexed and with the knee extended. That's 20 minutes of range of motion. Just to take a shotgun approach to see if you can catch something with that giant range of motion that you're finding. Versus having an idea of 3 or 4 very specific ranges of motions that I need to check just to make sure, and I take those very specifically off the table. Because one of the problems people are concerned about when it comes to the shapes is, that's 15 minutes. I don't have time for 15 minutes. You don't have time not to take 15 minutes. Because you spend 15 minutes getting a good idea of what you need to then get more information on. And instead of wasting 12 minutes on range of motion, your range of motion testing is done in 3 minutes because you have a very specific idea of what you need to do. You just saved 11 minutes. You finish and you don't have any concern of any kind of structural issues. Do you think you need to do any ligamentous laxity testing? Just took that off the table too. So the 15 minutes you invested has already saved you 15 minutes. So yes, if you're going to just do the shapes and then do everything that you normally would do without applying that thought process, you did add 15 minutes to your time. But if you filter through what the profile tells you, you can be very selective with the range of motions that you apply. You can be very selective with the mobility test that you may or may not want to do. Same thing with the shapes. When we talk about range of motion, we typically just think of the big ranges of motion: flexion, extension, abduction, internal, external rotation. But we also have to keep in mind the accessory motions, the roll, slide, and glide at each one of the joints. The arthrokinematics, the roll, slide, and glides at each one of the joints. At the knee, we have what the patella is doing. Patellar glide, inferior, superior, medial, lateral. As 100% of the time, if I have somebody that's lacking knee flexion, The very next accessory motion I look at is superior inferior patellar mobility. Because if patella doesn't slide inferiorly and superiorly as you flex the knee, it's not, you're not going to get into full knee flexion. Same thing if they're missing knee extension. I'm looking at superior inferior glide of the patella. Because if that's affected, it's going to affect flexion extension. Now, if somebody has full knee flexion, full knee extension, do you think I'm looking at patellar mobility? Not really. Palpation. I will say in 20 years of practice as an athletic trainer and teaching students and onboarding new coworkers, the tendency is, you're here for shoulder pain? Okay, well, it's been going on, it's been bothering you. All right, well, let's just go straight to our palpation. That's kind of like our safety net. It makes us feel good. We go right to palpating. They told us their shoulder hurts, they give us a little bit of information, we just go straight to palpating. It's like it busies our hands so we don't have to sit there and talk to the person. I don't think that's the best way. Because again, just like range of motion, what are you going to palpate? Somebody comes with knee pain, somebody comes in with knee pain, what are you going to palpate? Well, my knee hurts here. We're going to palpate right there. Well, they already told us it hurts there. What new information does that give us? Somebody comes in, my knee hurts on the inside, medial knee hurts, if they ever say medial knee. The inside of my knee hurts. And we start palpating, oh, that hurts? Yeah, your medial knee hurts. Yeah, I know, I told you that 3 minutes ago. What are we going to palpate? And again, just like with the range of motion, we can start to form a list, a checklist of these are the motions I need to check, these are the areas I need to palpate, these are the structures I'm concerned about that I need to test. And that test might be through palpation. But when we palpate, again, instead of, what I want you guys to start thinking of, instead of using these skills that we have as a shotgun approach, where I just palpate everything and see what I find, or I just do range of motion testing on everything and see what I find, instead, I want you to use these tools that you have the skills already of, very specifically. I want to look at this range of motion. What does this range of motion, what information does that give me? Early in my career, I was that person. Oh, your shoulder hurts? Right to the shoulder with palpation. Now, palpation is one of the last things I'll do. Because again, when I'm doing my palpation now, it's to answer a very specific question. Does that scar move? Does that joint line, can I recreate pain in that joint line? Is that inferior pole of the patella tender? What's the patellar tendon feel like? Is that a fusion in the joint, or is that a fusion, or is that edema outside of the joint? Do I have pitting edema, do I not have pitting edema? So now I've changed it to where, again, my palpation, I want to be very efficient and effective with my palpation. I'm not just randomly seeing what I can find and what I can feel with my palpation. Now, I might have my hands on the patient a lot earlier when I'm doing this. Again, because if they come in with knee pain, I might have my hands on their knee while I'm doing stuff with their neck. It's like that magic act. Distract you with this hand and the magic's over here. I might have my hands on their knee while we're doing different things, because in their mind, I have my hands on their knee. And that's what they feel and that's what they perceive. I might sit there with my hands on their knee. Okay, can you tuck your chin to your chest? Wonderful. That's what I'm paying attention to while my hand's over here on their knee. Strength. And notice the strengths in quotations. Because a lot of times we'll do a strength test for that person. If we're going to do a strength test, we need to be able to answer one of the very 4 specific things we're trying to answer when it comes to strength. Is this a size issue? Are we dealing with an atrophy, or are we in a situation where we need to generate hypertrophy? If somebody's been immobilized for any reason, we need to be getting that information so that we can answer that question. The objective measurement for that is actually just girth measurements. Unless you have an MRI in your pocket and you can get an MRI and then you can actually measure the cross-sectional area of the exact muscle and determine what that is. Most of us will just have to do it with the tape measure. We can do force production. One of the things we're going to talk about later on is we all learned how to do manual muscle tests with our hands, and it's a complete subjective waste of time if you do it like that. Because a 4 for me and a 4 for you guys isn't going to be the same thing. A 1 for me, a 1 for you guys isn't going to be the same thing. what you guys call a 3 today and what you guys call a 3 in 10 years isn't going to be the same. And why I say doing it just like that is a waste of time, it doesn't give us any information. Now, we can do the exact same techniques, and that's what we're going to talk about later this semester. I'm not saying what you've learned is a waste of time. I'm just saying, applying what you've learned right now, do other things. We can make a couple little tweaks, and the skills that you have, we're going to take those skills that you have that right now aren't the greatest, that actually give you some very valuable objective information without having to change anything that you're currently doing. So we can make a small little tweak, we can actually get some force production numbers, objective data to that, much more solid than the subjective way that we're taught. Again, not that that way is wrong, it's just not the most usable right now. We make a couple little tweaks, it's a very usable skill. We can look at muscle power. Now, as soon as we start talking about power and endurance encapsulate the time component. Power is how quickly can we generate force, endurance is how long can we sustain that force. So there's different ways that we can measure that, and when we get to that part of class, we'll talk about ways to look at that. But again, I'm not just randomly doing manual muscle tests to say that I did a manual muscle test. I'm to this point, I'm concerned about a strength issue. Which attribute of strength am I most concerned about? Is it force production? Is it size? Is it power? Or is it endurance? And when I get to that point, I'm going to do the very specific test that gives me the answer to that. Now, that specific test might lead me to look at other things. We had a patient yesterday, I helped somebody see. They were concerned that it was a soccer player. They were concerned they had a power issue. Like, okay. They're like, I want to do we need to go through a broad jump protocol. And this clinician wasn't 100% comfortable in doing that. I'm like, wonderful. I'll walk you through that. So I took the patient through this broad jump profile, and we found that there was a difference in single leg power between their right leg and their left leg. Like, okay, we have a power issue. So my next question to the clinicians was, have you actually put them on the leg press to see what left, right side was? Well, we haven't looked at that yet. Like, okay, because I know it's a power issue, do I have enough information to fix that yet? Because I know it's either a time issue or a force issue. What's the data that I need to be able to answer which one it is? I need to know how much force they can generate. And when I asked the question about force, they hadn't done that yet. So guess what the next thing we did was? We went and put them on the leg press and we measured force production. And that deficit on power that they had, that same deficit was there on force production. So guess what we're going to spend the first little bit of our time working on with this person? We're going to work on force production. Once we get that force production level up to the level that we need it, now I'm going to ask them to generate that force quickly, and we're going to retest that broad jump test. It's probably not going to fix a broad jump test, but now we've taken force off the table, now we can work on some power. And so that was the thought process that we went through to get to that point. We didn't just see that it was a power issue. The power issue led to another question. Now, as she said, yes, we've looked at force production, and both legs are fine, force is off the table, now it's a power issue. So our interventions are going to be completely different based off of the data that we have with that. And then, like I said, we can go to any of our special tests. Any of our ligament special tests, neuro test, reflexes, anything for the nervous system, vascular tests, tissue mobility, any of those, tissue hydration. We can look at any of our special tests. But again, as we're watching, as we're generating this profile of how this person moves, it's almost like while we're watching this happen, we're creating a checklist of things that we need to look at on the backside. I'm concerned about this range of motion. I'm concerned about, I need to palpate this area. I want to do this special test. I need to look at this mobility test. So that when we're done, now we go off of that checklist and we continue to evolve it as we go. Because like I said, if we find something with one of these other tests, we might need to look at a couple other things to get there. Much different than somebody comes in with knee pain and we palpate the knee, we range of motion test the knee, we do a couple special tests and we say, yeah, you have knee pain. Wonderful. What are you going to treat? And we have to get to that root cause with this. All right, so why is this important? The traditional athletic training assessment is we find a thing, we treat the thing, and we send them back to their activity. And in some settings, that is good enough. But again, I'm going to ask a question. We've come back to this a couple times. How many times do we have an athlete that has a hamstring issue? Is the only thing we're hoping for is the end of the season to get here, because we know that they're going to be dealing with that hamstring issue till the end of the season. And we just want to get through the end of the season so that they're not out on the practice field every single day, re-irritating that, and we give it time to heal. For most of our non-acute injuries, that's what we run into. We're hoping to limp them along far enough that time will take care of itself. And when I say traditional AT assessment, we can throw up there traditional PT assessment. You go to a traditional physical therapy clinic. And when I say traditional physical therapy, where they apply the traditional concepts of rehab, it's the same thing. We have 20 visits. Guess what the discharge criteria for most traditional therapy clinics is? Your last visit. The insurance company gives you 6 visits. We ran through 6 visits. We're discharging you today. But my knee still hurts. Okay, yeah, well, we had 6 visits. We ran out of visits. The discharge criteria is the limit of visits that you're approved by the insurance company. Didn't help them, didn't fix them. You just burned through the 6 visits. And now you've created a worse situation, because now you have a person that has knee pain and no more therapy visits. And if they want to go to therapy, they have to pay out of pocket. And that insurance, that most of those rehab places are very happy to take them out of pocket, because now they're a cash-based patient and they get paid more for that, when they don't have to deal with the insurance companies. So traditional thing is we find a thing, we fix a thing, we push them back into what activity they're trying to do. Now, we approach this from a healthcare provider standpoint. Let's take a step back, acknowledge that we can do a little bit better with this. We need to consider all the possible issues that are affecting the patient's reason for coming in to see us. This is why one of the things later on the semester, we're going to talk about how do we get an idea of the overall health of that individual. Because we can do all these great exercises, and we can have all these exercises that are going to create all the exact change that we need to, but if we have a health issue with that person, it's not going to work. Their system isn't going to adapt the way that we need to, because remember, we're using the exercises, we're using our interventions to create a very specific adaptation. If their system has other things that are a higher priority to their system, a physical adaptation is not going to make the list. If their diet is Skittles, chocolate milk, and chocolate chip cookies, sounds like the greatest diet you got, I would love that. Post-op patient, their healing process, the injury healing physiology that we know is going to take place is probably going to be slowed down. We're probably going to run into a situation where we have some tissue quality issues. It's probably a safe bet that the scar tissue that they lay down is going to be very weak. It's going to be very haphazard in orientation, and it's going to do nothing but give us problems. Why? Because when we look at how much protein they take in, they don't have enough protein to maintain normal day-to-day functions, let alone rebuild all this tissue that they have to build. We have to have the protein sources. And if all they eat are Skittles, chocolate chip cookies, and chocolate milk, you can't drink enough. It's hard to drink enough chocolate milk to get the protein needs that you have over the course of the day. So we have to consider all of the factors, not just they came in with knee pain or they had knee surgery. One of the things that's missed a lot of times, I will say physical therapy does this one really well. They objectively document the starting point. They objectively document where the patient is during that evaluation. And there's just a very specific reason why they do such a good job with that. What this does is it helps us generate medical necessity and need to actually treat that patient. And then we need to be able to objectively document the progression over the course of their time in therapy to show appropriate progression. If you guys go to any therapy anywhere in Southwest Missouri, Northwest Arkansas, Southeast Oklahoma, this region, it's going to cost you about $500 an hour, $250 for 30 minutes, $125 for 15 minutes. Because each of the billed units that get sent to insurance, depending on what 4 billed units that they get in an hour's time frame, comes out to about $500. So now here's a question. Is your time, is your hour with that patient? Did you provide $500 worth of service? Now, I said that physical therapy does a great job of objectively documenting their starting point because they need to get insurance authorization, insurance approval for them to treat you. And so how do they do that? They show problems. They find problems. They objectively document that there is a 15% strength deficit between the right arm and the left arm. They document that there is a significant range of motion decrease. They document that these ADLs are drastically impacted. Insurance sees that, they need treatment. There is medical necessity for treatment. We have that with the physician's referral, we're going to approve these visits. But if you don't objectively document that, there's no reason to treat the patient in their eyes. And we can get into this long philosophical question of, well, should insurance really be dictating whether or not a patient gets cared for or not? Absolutely not. They have zero idea, but they're also the one that's, when you were 6, and you went with your parents to the grocery store, if you were like me, you wanted to get the comic book, you wanted to get the soda, and you wanted to get the big bag of M&Ms or the Reese's peanut butter cups. Reached into my pockets, I didn't have any money. So what do? Hey mom, can I get all this? No, put one thing back. And then you're left with, well, do I want the comic book, do I want the soda, or do I want the candy? Depends on how I'm feeling. Okay, I put one back. Well, soda or candy, pick one. You have to get the approval to spend the money that's not yours from the person who holds the purse strings, which is mom or dad, grandma, whoever took you to the grocery store. You have to ask them for approval. It's driving me nuts right now. Dad, Jordan 4s, red concrete. They're on StockX, $225. They're cheaper than at Christmas. Wonderful. Get $225. I'll order them right now. And don't forget, we'll probably have to pay shipping and taxes, so you're probably gonna need to get about like $240, $250. How am I supposed to order $250? I don't know. You want the shoes? Make it happen. Well, I asked you. You did, and I said no. That interaction between Callan, and that was the discussion on shoes yesterday. The day before that was Harden 7s. And the day before that, it was pick a shoe. I mean, we go through this every week. That's what it's like with insurance. We're that kid asking the parent for money to buy something. And I'll be honest, if Callan's being a little turd, and he's on my last nerve, and he's like, Dad, shut up. I don't want to hear it. No. I don't care what you can ask. No. And he takes after his mom. He hasn't picked up on this. If he's nice to me, if he's helped me out, if he's done some things for me, if he approaches it a little bit softer, I'll at least listen to him. I'm probably still going to say no, unless it's a really good sailor. I like the shoes and I'm going to wear them. But you have to provide something to convince them to give you the money to do the service that you're dealing with. And we're talking a significant sum of money. I think it's important to understand, because one of the things, well, I'm in a high school setting, I'm in a college setting, we don't deal with this. You're right, you don't necessarily deal with billing the insurances, so you don't have to worry about providing $500 worth of service because nobody's paying you $500 for that. But we do still have to objectively show a starting point, and we do have to objectively show progression. And I'll go back to the State Practice Act real quick with this. It's important for us to understand what our State Practice Act says. Because if we're operating within the State Practice Act, wonderful. If you're operating outside of the State Practice Act, you're out on a limb by yourself. And in Missouri, we are athletic trainers. We're open access individuals, which means a patient can come to us and say, my shoulder hurts, and we can treat them. The State Practice Act has changed and allows us to do that. However, and we don't need a referral when they come to us and they say, my shoulder hurts. However, in 21 days or 10 visits, whichever comes first. So in 21 days, if you only see the patient twice, it's 21 days. If you see the patient every day this week, every day next week, you've burned through 10 visits in 14 days, it's the 10 visits. So 21 days or 10 visits, whichever comes first. In 21 days or 10 visits, you have to show significant improvement from day one. Well, if you don't document, can you show significant improvement from day one? You can't. patient says, my shoulder feels good. If it's not documented, it didn't happen. So if you didn't document stuff on day one and you didn't document stuff here that shows an improvement, you're now at this point, you can't treat that patient anymore. You have to send them to a physician. If you don't, you're operating outside of your State Practice Act. If you're treating somebody with a neurologic condition or a cardiovascular condition, an actual diagnosed neurologic issue, a diagnosed cardiovascular issue, if you're operating in a clinical setting, you can't see these patients. So I can't treat these patients. Somebody comes in and they had a patient not too long ago. They came to me and they're like, yeah, they were referred to me by an acquaintance, and they're like, yeah, I'm just having a lot of balance issues. You know, I want you to, if you can help me work on some strength stuff, and they're telling me all this stuff that they need. I'm like, okay, we'll see what's going on. And so as I'm talking to them, within the first 10 minutes of talking to them, they'd been diagnosed with Parkinson's 2 to 3 years ago. And what they're dealing with are the symptoms of Parkinson's. As soon as we got to that point of they have a diagnosed neurologic condition, I can't treat them anymore. I can, but I'll be violating the State Practice Act. Now, it gets a little asterisk. There is an exclusion clause to this. If you're working with a professional or an amateur athlete that is participating in sanctioned athletic activities, you have a window where you can treat that. So our college athletes, our high school athletes, we can actually take care of some of those. Now, most of those athletes aren't going to have Parkinson's disease or an actual neurological condition. But the wording is neurologic condition. Bless you. Is a concussion a neurologic condition? It's a gray zone. But in the high school, in the collegiate setting, you're excluded from that because you're dealing with amateur professional athletes. So we have to be aware of what our practice act says, because even if we're not billing an insurance company, to legally be able to continue to see that patient, we have to be able to objectively show a starting point and progression every 10 visits, every 21 days, every 10 visits. Got those out of order. So we do still need to show medical necessity. We do need to have objective documentation as to our starting point. Manual muscle testing, as we're all taught, isn't objective data. We can put numbers to it at 3 out of 5. That's not an objective data point, because that 3 is very subjective. Like I've said before, my 3, your 3, not going to be the same. My 3 today, my 3 in 2 years isn't going to be the same. Again, skill that you have, few little tweaks, we can make that objective data. We have to show objective data. Range of motion, we can put some degrees on that with a goniometer. We can objectively measure strength. Special testing, well, how objective is that? It's still kind of subjective, yes, but we do have criteria for what is a positive test on a Lachman's or a Valgus or a Veris test. And if they meet that criteria, we can say that it's a positive test, and that is an objective test. So because we have the established criteria, we can determine pass or fail, or is it a positive test or a negative test. That gives us the objective data. And then we get into ADLs. We have to be able to document our ADLs. And this is one of the things in the collegiate and in the high school setting we tend to overlook a little bit, because we're not trying to get them back to being able to be a normal person. We're getting them back to be able to run, jump, cut, and play basketball. So we tend to overlook the ADLs a little bit. So with the shapes, depending on which shape they do well on, which shapes they fail, if somebody doesn't do well on certain shapes, I have a specific list of leading questions I'm going to ask them. I'm not going to ask these for everybody, but I am going to ask some very specific leading questions after the profile in our conversation. If somebody's getting into the bottom of the deadlift, and this is what they look like, obviously that doesn't meet our criteria. So over the course of the conversation, hey, during the day, on the weekends, if you're doing a lot of up and down stuff, you're bending over a lot, how does your back feel as the day progresses? Or in the mornings, you're putting on your shoes and your socks, do you have any difficulty with that? You go to we just had ice this weekend. Did you have to shovel your driveway? Or did you have to put salt down? Did you have to pick up a bag of salt? Did you have to put some stuff in your truck? How does your back feel when you bend over and have to pick stuff up? I'm going to ask a series of leading questions to get more information about their ADLs. Because in a clinical setting, we have to document the issues in their ADLs from a medical necessity standpoint. Again, in the high school, the collegiate setting, that's not as important. It can give you more information, but it's not as important as if you're dealing with somebody that's outside of the sport world. Now, you can tweak a lot of these questions to, hey, okay, you failed out in the deadlift. In the weight room, when you guys, do you still deadlift? No, it hurts my back too much. Okay, what do you do instead? Well, he has me doing this instead. How does that feel? Because if a strength coach is going to take an exercise off, they're going to replace it with something that's kind of not that exercise, but in the ballpark. And if it's in the ballpark, we knew that deadlifting hurt. Whatever they replace it with in the ballpark, we probably need to get an idea of how that feels. Or, you know, when you're in basketball practice, you guys do that one defensive drill at the end where you're in this position and you slide back and forth for days on end. How does your back feel with that? So we might not ask the same questions, but we can ask questions that are specific. We can use those questions as a reference to ask more questions about their sport or their specific activity. Patient recorded outcomes, we're going to talk about this later on in the semester. Do you guys know what the HOOS is? Yeah, it's a hip disability and osteoarthritis outcome survey. If you scan the QR code, it'll actually take you to the HOOS and you'll see what all the questions are. And they're just normal day-to-day questions on how does your hip feel when you put on your shoes? How does your hip feel when you take a shower? How does your hip feel when you get out of the passenger side of a car? And you have a 0 to 5 scale. They have the same thing for the KOOS. They're very original in the naming. It's the Knee Disability and Osteoarthritis Outcome Survey. Same thing, it asks specific questions about how the knee feels during ADLs. It's important to be familiar with these. Again, college, high school setting, you're probably not going to have to deal with these a whole lot. But if you get out of that setting, there are insurance companies that require on visit 1, you submit the KOOS or you submit the HOOS. There is a HOOS Junior and a KOOS Junior, which is just a 5-question version of each one. So you will at least need to be aware of them, where to find them, how to apply them. I always think it's a good idea to go through and ask these questions, have an idea of what's on these questions. We had, it's been a little while back, there was one insurance company that we were dealing with a lot, and it was, patient we were seeing was a 14-year-old male with shoulder pain. 14, 15-year-old male, junior high age male with shoulder pain. And insurance required, the insurance that they had required on day 1 for us to do the dash. Well, the clinician that had graduated from this program, they were within their first year of practice. Our front office lady was like, hey, you need to run this person insurance. I have to send in a dash. Here's the form where you just ask the patient where you have the patient go through and ask them these questions. And so the clinician was like, yeah, sure. Well, instead of just handing the paper to the patient to fill out, it's a 14-year-old, it's a junior high kid. I'd have probably done the same thing. Instead of handing it to them where you know they're not going to read it, they're just going to highlight things and circle things, the clinician decided, I'm going to ask them the questions and fill it out for them, which is, like I said, I would have done the same thing. Now, the thing I would have done differently, before I read these questions to this junior high age male, I would have made sure I was really aware of what these questions were, because it was a very awkward silence when you get to the question about sexual activity. Could you imagine how awkward that 13-year-old felt at that point in time? Can you imagine how awkward you would feel if you were asking that 13-year-old those questions? So the clinician wasn't aware that that was a section on there, and then when they got there, they didn't know what to do, so they just kind of froze up, and they read all the questions, and the kid just sat there like this, no, 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 and it was a traumatic experience for both of them. In hindsight, it's a very good story. I laughed at them, and we turned it into a learning opportunity. I'm like, what did you learn from this? He's like, I learned I'm never doing the dash again. I'm like, no, no, what did you learn from this? He's like, well, probably should have been more familiar with that tool beforehand. I'm like, yeah. Had you been more familiar, what would you have done? He's like, well, I just wouldn't have asked those questions. I'm like, you're right. It's like, now, you also could have got there, you read that first one, I don't know how your mind works, but I read something and there's a little delay before it comes out of my mouth. You could actually, in that little delay, decided to move to the next section. He's like, well, I thought I had to do it. I'm like, well, just give them all fives, make it up. I'm not going to question you if you do that. So it's a learning experience for all of us. So I think it is a good idea if you're in a situation where you have to give these out to patients or have patients fill these out to have an idea of what's on there, because they will ask you questions, or you might want to adjust it for them. Why is changing this process of our assessment important? Because we have to have a process. Every time we treat a patient, it is going to be different. Every time you assess the patient, it is going to be different. But we need to ensure that we have a consistent process that's serving as our framework for how we're approaching it. When we look at the shapes, it gives us our consistent starting point that's going to answer one of three very specific questions. And remember those three questions that we're trying to use this for. What is this individual's overall movement behavior like? We're creating that profile of movement. They come in with knee pain, they come in with back pain, they don't know what led to it, they've got 6 or 7 different things going on. We're going to start out, use this as our anchor point to help us with our thought process as we move forward. I had a patient, the patient I was telling you about with the broad jumps. I had been introduced to this patient for a solid 60 seconds before we were going to get into this. I needed to do broad jumps with this person. I don't know what's going on with this person. Guess what I did with this person before we did broad jumps? I put them in standing, looked at them in standing. I put them in bottom and deadlift, looked at them in bottom and deadlift. They passed both. I felt comfortable going through a warm up and having a broad jump. Now, had they failed bottom and deadlift, do you think I would have had them do broad jumps? I wouldn't have. And that would have been an awkward situation, because that was what the clinician wanted me to do. They didn't meet the requirements. We have some other things that we need to check off first before we get to power, but that's valuable information, because now is this a power issue or is this a postural issue? So if we know that we're going to be applying a strategy, or if we know that we're going to be loading a position, we can use these selectively, we can use all of them to help us answer these questions. And that gives us a safety net. Because had I not asked this kid, had I not gone through those 2 shapes with that individual and had it on the broad jump, and he on his very first broad jump, he lands, his knees collapse, and he tears both of his MCLs. Yeah, I went very dramatic on that. But I was the one that did it. I was the one that had them do that. I could, in my position, say, well, dang it, Brandon, why did you ask me to do this with this person when you knew it wasn't a good idea? I could deflect the blame to him, because he was a clinician, was working with the patient, and he knows more about the patient than I do. I only knew what was going on with this patient for 2 minutes. But I still ultimately made the decision to do the broad jump with them. And then I'm going to get asked, well, why did you make the decision to do the broad jump? What in your clinical judgment let you know that it was safe to do the broad jump? Well, Brandon said that's not clinical judgment on my part. So even in that situation, I don't think that Brandon was lying to me, but I need to make sure that I'm comfortable doing this. Had the individual gone through the profile before? Yeah, the clinician had taken them through the shapes. Could I have said, hey, did they pass bottom and deadlift standing? They could have. I could have. But it's Missouri, it's a show me state. I wanted to see that this person looked good before I went forward, because I could say, well, I had them do this. We went through the warm-up. Everything looked good. There was nothing that gave me any idea that this was going to be a bad idea for this person. I did this objective test, I did this, I did this, I did this. Or versus, I said hi and I had them broad jump and they hurt their knees. What's the big deal? So it gives us a little bit of a safety net, especially when we get into some of the things that we need to do from a rehab standpoint, especially when we get into the exercise portion of what we do. You have that person that we decide we're going to do deadlifts with. How do we know? Let's just say you have a protocol that says today we're going to do deadlifts. How do you know it's safe to do deadlifts with that person today? Well, the protocol said that's not good enough. Protocol said do cartwheels underwater for 100 yards. Are we going to do that? I might try it, but can't do cartwheels on the ground. we need to be able to safely say, yes, this was a good decision, or we didn't do this because it was a bad decision. Just a reminder on the strategies. Single coordinated weight shift or upper body push pulls, horizontal, vertical. There's also our 2 coordinated weight shifts, 3 coordinated weight shifts for the asymmetrical strategies, and 5, which is our transition stuff. All right. That's the last slide in regards to reviewing the movement profile.